We're going to talk about, first of all, the theoretical base that you should all have in order to know which uroliths should be retrieved endoscopically, which uroliths should be handled medically. And in part two, the next time, after we have built up our knowledge and we have built up an internal medicine, the internal medicine basics, then we can go on into the procedure per se, which means describing the instrumentation, describing the procedure in order to take out the uroliths from female and male dogs. So this is kind of more or less the schedule that we will have. So we will talk about crystaluria, we will talk about urolithiasis and how they're formed, which is in a more theoretical basis this time. But I think that it is imperative for you to know as veterinarians which ones will end up endoscopically managed and which uroliths can be managed medically, or which ones should go into the surgical pathway, should be handled on a surgical pathway. As June said, we upload many cases in YouTube channel, and feel free to get in contact with me if you have a difficult endoscopy case or internal medicine case, because we do consultations all over Europe, the Middle East at this point. So I'm more than happy to assist you and help you out with your cases. Okay, let's go on. So this is an open access source that you can all download and have in your practices. And these are the SVIM small animal consensus on and the recommendations about the treatment and prevention of uroliths in dogs and cats. And as you all may know, prevention is much better than treatment. So this is an open access source that you can all have for any type of uroliths and what is the recommended route. So I want you to download it and have it in your practices, as well as the other SVIM consensus statements, which are very helpful because they give you an overall view of the pathology, they give you an overall view of the diagnostics, and an overall view of the current treatment, even the latest treatments. Feel free also to have questions, in the chat box throughout the presentation if somebody wants to open their head. So, what is a urolithiasis? Is a urolithiasis the final diagnosis? So, this is a pathological condition. It's not a specific disease, it's not a specific pathological condition or syndrome, but this is the outcome of a combination of multiple factors that contribute to the formation of the urolith. So this means that it's the outcome of congenital factors, and we will talk about the breeds that are predisposed, of some acquired predisposing factors, and this end up to having uroliths, which can be any size, any shape. We will talk about the different sizes and shapes. So what are the predisposing factors? And on my left, you can see the most common breeds that we can find urolithiasis. Okay, and there are many more, and each one of these breeds is predisposed to a certain type of urolithiasis, which has to do with the metabolism. So the predisposing factors could be roughly put in three main categories, categorized in three main fields: the treatable, the curable ones, the non-treatable, and those of unknown cause. So the treatable and curable are the urinary tract infections, hypercalcemia, especially on the basis of hyperthyroidism, drug-induced like allopurinol, and allopurinol is a drug that we definitely use here very commonly in the Mediterranean countries because we have leishmaniasis. I don't know if it's a common disease in your countries, because we have a multinational audience, please send a message in the chat box so that we can see. And the second category are the non-treatable ones, like the defects in uric acid, in the metabolism, in its metabolism in the Dalmatian dogs, or the excretions of large amounts of urate in the urine, like the English bulldogs, or the Dalmatians as well. And sometimes we do not actually know the cause. So, and this, a very, very good example of that is the calcium oxalate uroliths in Schnauzer dogs. So in one study in miniature Schnauzers, they had higher urinary calcium excretion during fasting than Beagles. And the urinary calcium excretion actually increased 3 times, 3-folds up after feeding. And that's, you know, that's extraordinary to know about the Schnauzers, because this is a main predisposing factor for the uroliths formation. Okay, so we have to think about the breed, we have to think about the underlying factors in order to actually know how the dissolving of the uroliths might take place. And what are the 3 theories? What are the what is the underlying pathology of how the uroliths are formed? So first, we have the precipitation crystallization theory. We're not going to go into pathology very much because we are an endoscopy community. But as I said, we have to know those things because endoscopy is linked very, very closely with internal medicine. So we have the precipitation crystallization theory, where we have a supernaturation of urine with crystalloids and salts like magnesium, ammonium, calcium, oxalate, phosphate compounds, low urine volume, pH, and temperature. The second theory is the matrix nucleation theory, where some organic material, the matrix, which is called the matrix, and plasma proteins like Tam-Hirschfeld proteins can actually form the nucleus. And then in any urolith, we have to know that the organic part is much, much smaller than the crystalloid part. Okay, so we have a nucleus of an organic material, and around that, the urolith is formed. And then we have the crystallization inhibitory theory, where the absence of critical inhibitors like the Tam-Hirschfeld proteins, the glucosamines, and you know that the GAGs were actually a therapeutic measure to the feline idiopathic cystitis syndrome, because we knew that the lack of them could actually predispose to urolith formation. Anyway, the research there didn't find any, any positive effects from the administration of glucosamines and chondroitin, but there was a lack there was an absence of GAGs in these syndromes, urinary syndromes. Other critical inhibitors of urolith formation are nephrochalcine, citrate, pyrophosphate, and bisphosphonates. Okay, so in the absence of those critical inhibitors, the urolith formation is facilitated. Or we can have on the other hand, the presence of promoters of crystallization and aggregation through a process that is called epitaxy. Let's refresh our knowledge of Greek and terminology. So Cosmin is asking, hi, for humans, uric acid problems and Guta is utilized allopurinol. Is it available for animals too? Yes, the uric acid, yes, this is allopurinol, can be used for diminishing urine acid in dogs as well, but we don't have that many problem with elevation and increasing of urine acid in dogs as we have in humans. Okay, and it's a matter of metabolism, of totally different metabolism, but it's some diseases like protozoan diseases like leishmaniasis, we can use it because it has antiprotozoic properties as well. Very, very nice point. Thank you, Cosmin. Thank you. So let's first talk about crystals and the differentiation from uroliths. Okay. So we're gonna talk about some myths, okay, that you will. I should have actually hidden the answer, and we should have made it more interactive in terms of true or false. Okay, and let's talk about some statements and see if they're true or false. So the presence of crystalluria, this is the statement. The presence of crystalluria indicates that uroliths already are present or that their formation is inevitable. So now I already have the answer here, but what would you answer here? If we have crystalluria, does it really indicate that we already have uroliths, or that the formation of uroliths will happen in the next months or over the next period? And of course, this is false. In many urine exams, in urinalysis, we can see crystalluria, but this is not a synonym of urolithiasis, as you see. Many healthy animals have crystals in their urine and will never form any kind of urolithiasis. And also, the presence of struvite crystals, especially in dogs that do not have a urinary tract infection, will not always be a predisposing factor for urolithiasis. So if I have struvite crystals and there is not an underlying urinary tract infection, then no uroliths will be formed. But if at some point I have a complication of a urinary tract infection, then yes, at that point, struvite crystals might form a struvite urolith. And cystine crystals, for example, are not found in the urine samples, but not all dogs with cystinuria will develop urolithiasis. So you see that we might have cystinuria as well, but not every dog will eventually develop cystine uroliths. So this is a false statement. And whenever in your urinalysis you're seeing crystalluria, it doesn't necessarily mean that this dog will eventually progress into forming urolithiasis. Okay, let's go to the second one. The absence of crystalluria ensures that no uroliths are present in the urinary tract. So let's say that we are doing a cystocentesis, or we're taking, the owners are bringing you a urine sample with free urination, and you're doing a urinalysis and you don't find any crystals. Does this mean that the dog does not already have uroliths in the bladder or anywhere else in the urinary tract? And of course, that's false. Many animals with confirmed urinary stones have no crystals at the sample at the time when the sample is collected. They might, you've seen the theories just a bit earlier, they might be on the stone. All the crystals might be on the stone because we have the crystallization theory. Okay, and to even make it worse and to even make it more difficult and challenging for us veterinarians, 50% of calcium oxalate uroliths are not combined with crystalluria. And this is why when we diagnosed, when we are in the process of diagnosing the uroliths, we need some kind of imaging, especially for the calcium oxalate uroliths, which, as we will say, They are all radiolucent, so we can see them in the radiographs. Okay. Are you surprised with these two statements? I know that you're very good and you probably already knew. So what is the true significance then of crystalluria? What do I do when I see in my urine samples that I have crystalluria? So when a urolith is present in the urinary tract, let's go to the other statement. When a urolith is present now in the urinary tract, its chemical composition is always reflected in the type of crystals observed in the urine sediment. True or false? This means that when I have a urolith in the urinary tract, and I also have simultaneously, I have crystals, do they always have to be of the same type? And of course, that's false. A surprising number of animals with confirmed stone type have a totally different type of crystals, or none, as we said, in their urinalysis. Okay, so when you see, for example, you take a urine sample and you find crystals, and you know that there's a stone in the urinary bladder, for example, or in the urethra, and you presume, okay, I found these crystals in my urinalysis, so this stone should be, for example, calcium oxalate or struvite. This is wrong. The assumption is wrong. You should, of course, verify it, but you might have another type of urolith. Okay. So to sum this up, and I hope it wasn't too confusing for everyone, crystalluria may be found in animals without urolithiasis and may be absent in animals with urolithiasis. Okay, that's a bit tricky. And the crystals present in the urine sediment may differ from the composition of the urolith. This is what I really want you to, this is the take-home message that I really want you to remember. Okay. And what about in vitro fake crystalluria? So the crystals are formed after the collection of the urine sample, and they do not have any clinical significance. This is what the in vitro fake crystalluria means. So I know that during the course of your consultations in the clinic, it's very difficult to take the urine sample, and if you don't have a designated lab, to have the urinalysis at that time of the collection, then you just leave it in the lab. And when you finish all your cases, then you go into doing the urinalysis, which is very, very wrong. And it will cost you in diagnosis, I mean, because you might have in vitro fake crystalluria. So crystalluria is a very, very common a normal physiological phenomenon when the urine sample is stored under refrigeration for more than 1 hour. This is why we're trying to do the urinalysis in about the 31st minutes of the collection of our sample. Another thing that might predispose to in vitro fake crystalluria could be the evaporation of the urine sample by exposure in high environmental temperatures, especially for us living in the Middle East, in Greece, in the Mediterranean countries, and especially during summertime. This is a huge component. Okay, the delayed examination of the urine sediment, the urine pH alterations due to an underlying urinary tract infection, and the most common in vitro crystals that we are encountering are the struvite and the calcium oxalate crystals, with the struvite, I think, passing the calcium oxalate crystals. This is my experience. Please write in the chat box your experience as well. So don't put it in the fridge. Try to make the urinalysis the soonest possible in order to avoid the in vitro crystalluria. And some other tips, because I know I'm not in only in academia, I'm mostly in clinical practice, and I understand all the problems that you are encountering because I have been there. So some helpful tips: urinalysis should be performed 15 to 20 minutes after collection and before storing into the refrigeration. And if you, let's say that you don't have time and you really have to refrigerate your sample, then you should take it out of the fridge, return it to room temperature before analyzing it. Okay, so we said that crystal urea has to be interpreted under a very, very cautious magnifying lens. Okay, so we might have crystal urea in dogs that do not have urolithiasis and that will not proceed into forming uroliths. We might have uroliths without crystal urea. We might have fake crystal urea. So if I find crystals, when is this an alert? Okay. When does actually crystal urea demands a careful evaluation? I know that we're not talking about endoscopy per se right now, but I want you to have a full overview so that, yes, somebody's asking if you're going to have the PDF. Carol, yes, bonjour, bonjour. You're going to have the presentations in recorded. So don't worry, you're going to have everything so that you can have a full overview of how we approach crystal urea, crystals, and also the endoscopic procedures in part 2 as well. So when do we actually are scared about having crystal urea? And we know that these animals need closer monitoring. So persistent and severe crystal urea in breeds with predisposition. And we've said about which breeds are predisposed, like Dalmatians, English Bulldogs. So if you have a Dalmatian or an English Bulldog or a Schnauzer with persistent crystal urea, then these are red flags. Okay. Persistent presence of ammonium urate crystals in breeds that are not predisposed. So let's say that you have a mixed breed dog that persistently, especially young in age, but let me say that, not only young in age, because we have seen portosystemic shunts with smaller vessels, smaller shunts that are not being perceived in a younger age. And we can see 4-year-old animals and 5-year-old animals having portosystemic shunts. And if these animals were if these animals had undergone a urinalysis prior in their lives, they might have been earlier diagnosed. Okay, so persistent presence of ammonium urate crystals in breeds that are not predisposed, this could be a problem as well. Crystal urea plus urolithiasis. So we've said about the differentiation, but if you have crystal urea and you have already formed crystals, then even in the past, then this means that this animal is predisposed and should be closely monitored. Okay, previous clinical history of urolithiasis, of urethral obstruction, and after the removal of uroliths, if you have recurrence of crystal urea, this means that something is not balanced very well. The pH, maybe the specific gravity, and you have to intervene with medical treatment there in order to avoid forming further uroliths. Okay, crystal urea plus clinical symptoms from the lower urinary tract. Maybe a urolith is absent, is not there. But if I have crystal urea and clinical symptoms from the lower urinary tract, like dysuria or stranguria or hematuria, then this means that this dog should be monitored closely. Urinalysis, UPC, cultures, in order to see if, in order to avoid urolith formation and in order to actually diagnose the underlying pathology. Okay, dysuria, of course, we all know that it's when animals cannot urinate properly. Stranguria is when they when they actually urinate very small amounts, multiple times, okay, and when they're struggling to urinate, and hematuria when they have either blood or hemoglobinuria, which has to be differentiated as well. Okay, so these are the events where we have to closely monitor animals that have crystalluria. And let's go to each and every one of the crystals. What about struvite crystals? So struvite is of limited clinical significance, and I will definitely say that multiple times, because I know that you're seeing dogs, you're having a urinalysis, and then you're putting dogs under clinical diets like urinary or SD or whatever, due to the fact, only based on the fact that you had crystalluria without any UTI. So this is of limited significance, unless they are combined, especially in dogs, because we're talking about dogs now, with urinary tract infections from ures and other organisms, microorganisms like Proteus, Ureaplasma, Staphylococcus, Pseudomonas, Klebsiella, etc. Okay, so we don't care about struvite crystals unless they're combined with urinary tract infections. And we're talking about dogs, because in cats, it's different. Okay. What about calcium oxalate? Oh, and about the formation, I'm sorry, you see that they have this coffin. We're going to talk about the shapes, but most of the times they have this coffin-like appearance. Okay. And then we go to the calcium oxalate crystals. We can have dehydrate or monohydrate calcium oxalate crystals. These are the cross of Malta because they resemble to the flag of Malta, the envelope, okay. And the other formation of calcium oxalate crystals are the fence, okay. The second picture. We could actually see them intermittently in healthy dogs. And when we have persistent crystalluria, we should always consider hypercalciuria. Hypercalciuria could be absorptive, could be renal, a leak, or reabsorptive, or we can think either hypercalciuria or ethylene glycol toxicity in dogs, okay, where we will have monohydrate oxalate crystals and compatible, of course, clinical symptoms of an underlying toxicosis. And ethylene glycol toxicity, do you know what is the most common source of dogs swallowing, licking ethylene glycol? Does anyone know? If you know, put it in the chat box. It's very interesting. How can a dog or a cat be have a toxicity from ethylene glycol? That's really super. And this is why we are seeing it in dogs and cats that are strays and that are leaving. Yes, I think that I have an answer here. Yes, from the car edging. It's actually from the antifreezer of the antifreezer of the for the car engine. Yes. And this is why we're seeing it, especially in dogs and cats that are leaving gas petrol stations. Okay. And it's very, very sweet. And we mostly have dogs because cats cannot actually sense the sweet taste. Okay. And we mostly have dogs drinking ethylene glycol, which was a bit, you know, this is a nice information. And it's good to know. Thank you. Thank you, Burku, for the input. Okay. And then we have cystine crystals. Let's go to the more, you know, not the most common ones. These are hexagonal, as you see. And there's a tip here. They're almost exclusively found in male dogs, okay, male intact dogs. So if you have a male intact dog, and you see cystine crystals, then they are cystine crystals. Both male and female Newfoundlands are affected. Okay, in Newfies, it's different. The only breed that we can find it also in female dogs are the Newfoundlands. Okay. And when observed in the urine, they should always be considered abnormal. So if you have a male intact dog, please think about cystine crystals as well. Canine cystinuria is an inherited disorder, okay, of the renal tubular transport involved in cystine or cystine plus other amino acids like orthonine, lysine, and arginine, okay? And it is inherited as an autosomal recessive trait in the Newfoundlands. And this is associated with a mutation. This is a very, very thorough now presentation. So it doesn't, I don't care if you don't remember the mutation in the specific gene of this amino acid transporter. But this is the gene for those of you who really want to delve into more details, okay? The SLC3A1 gene. In other breeds, cystinuria, as we said, is genetically heterogeneous. And in other dogs, as in humans. So in every other dog, we actually find it only in male intact dogs, with the exception of Newfies, where we can find them both in male and female dogs, okay? And cystinuria decreases in severity with age, especially when they pass the threshold of 5 years old. So you might find very, very intense cystinuria in male intact dogs that are genetically, that have these inherited disorders when they're 1 year old or 2 years old, okay. But once they pass these dogs are aging, you might see less and less cystinuria in their urinalysis. Okay, so not all dogs with cystinuria will develop eventually urolithiasis, and we will say how we will manage these uroliths. What about ammonium biurate crystals? So especially in Dalmatians, which were very, very cautious when we see these uroliths. Okay, the proximal tubules of Dalmatians reabsorb less and secrete more urate than do the kidneys of any other dog, leading, of course, to the urinary urate excretion. Okay, the defect in the uric acid metabolism in these dogs is not caused by the lack of hepatic uricase, as in other dogs, as in other breeds that do not have this defect, okay? The abnormal finding can be found in other breeds, except Dalmatians and English bulldogs as well. They are in other breeds, apart from these two breeds, the Dalmatians and the English bulldogs, they might indicate portosystemic shunts. Okay, so we always have to evaluate these crystals. And we can also find them transiently after chemo protocols. Like, for example, if you do a CHOP protocol for lymphoma, you might find these crystals transiently in your urinalysis. Okay. What about xanthine crystals? Xanthine crystals, and I have the pictures of all the crystals just next to their description. Xanthine crystals, somebody raised their hand. If you want to ask something, please go ahead and do it. Xanthine crystals form due to deficiency or inhibition of this enzyme, the xanthine oxidase enzyme, okay. Congenital, there is also congenital xanthinuria. I wanted to have all the details here for you to have them in one slide, okay, for every crystal. So congenital xanthinuria has been reported in Cavalier King Charles Spaniels and in a few Dachshunds, but the Cavaliers are really, we really have to monitor them. And the mode of inheritance is autosomal recessive pattern in the Cavaliers. Also, you might find a lot of xanthin crystals in dogs that are administered for leishmaniasis allopurinol, okay, because allopurinol actually inhibits the xanthin oxidase enzyme. And this is one of our huge problems here in the Mediterranean countries, that we're treating dogs with leishmaniasis. We have a lot of xanthinuria in these dogs after a prolonged treatment with allopurinol. Okay. And also, as you say, as you see in the previous question, this answers actually your question about urine acid, Cosmin. Allopurinol is used to manage cases of ammonium urate urolithiasis because it leads to the decrease in urine acid. So it has the same mechanism just as in humans, although the underlying pathogenicity is not as common as in humans. Okay. We use it in order to treat leishmaniasis, as I said, and they should always be placed in a low purine diet. We're going to talk about diets a bit later on. And there is this difficulty into differentiating the ammonium biurate crystals from the xanthin crystals. You see that they're pretty much, the same, apart from the fact that the ammonium biurate crystals are a bit more, they have more prominent spikes. And you can see the xanthin crystals. You can easily confuse them. Okay. And let's talk about, bilirubin crystals. And me as a gastroenterologist, this is a very, very common thing to see. It is a normal finding if you have in highly concentrated urine, if you have urine with a specific gravity of, let's say, 150 or 148. This is why I really want your urine-specific gravity meters to be more than 145. Okay, definitely more than 135, because I know that there are many in the market, but I really want you to use a urine spectrometer that can actually measure up to 150 of urine specific gravity, because otherwise you will lose many diagnoses of concentration of concentrated urines, and you might over exaggerate in your diagnosis in bilirubin crystals, for example. Okay, so your refractometer has to have a scaling of more than 135, at least more than 140 to be on the safe side, okay? So when they're present in very high numbers in an unconcentrated urine, so let's say that we have a urine-specific gravity of 1025 or 1020, okay? These crystals suggest some kind of an abnormality in the bilirubin metabolism. Either we have severe hemolysis or cholestatic disease, liver disease. Okay, so they might indicate liver disease, and they might also indicate severe hemolysis. And you really have to also discriminate between these two, to make a differential diagnosis between hemolysis and liver disease as well. You might have jaundice, okay? And you really have to take the pathway of how to approach jaundice after that, icterus, okay? And it's always present. That's a very, very good also recommendation for you to take a urinalysis, because bilirubin crystals will always be there prior to hyperbilirubinemia, okay? Just before the total bilirubin in the blood is actually increased, you will have the formation of these crystals. So this is very, very important. And I always say, please do a urinalysis that can give you so many information. For example, you have a dog with gastrointestinal symptoms, and you take a urine sample, and you have a low cholesterol, and you take a urine sample, and the specific gravity is very, very low, like 1020. then you should definitely think about Addison's disease. If you have a dog with gastrointestinal symptoms and you don't have electrolyte measurements in your practice, for example, okay, you cannot measure potassium and sodium at that point. And you really want to know or cortisol levels, and you really want to know, what am I going to do? Is this an Addison's, an Addisonian or not? Measure also a specific gravity before putting the dog, of course, in IV fluids. If the specific gravity is around 120, I'm not saying that this is diagnostic 100%, but it is indicative of Addison's disease, okay, due to the low potassium, to the low sodium excretion, okay? So do your analysis. I don't know if we have any questions up to here. I'm going to go into the uroliths, which is our interesting part, and how we can intervene as endoscopists as well. You can see that there are many uroliths, many shapes, many forms, and we're going to go through them. What about the epidemiology? It has changed a lot over the years, and the reason being that we are feeding our animals totally different foods. Okay. And of course, the epidemiology has also to do with the countries. It's different in the US and different in Europe, and totally different in the Middle East due to the environmental conditions as well. So most uroliths are created or located in the lower urinary tract, bladder and urethra, and less in the upper urinary tract, kidneys and ureters. And I was actually in Barcelona for ureteral stenting right now, which is really difficult procedure. We're going to talk about more advanced procedures maybe next year. Most of the uroliths are struvite and calcium oxalate, 80%, more than 80% of them. And most uroliths are simple. So most uroliths, lower urinary tract, struvite or calcium oxalate, and simple uroliths, not mixed types, okay? And the epidemiology over the years, you see that the progression from 1985 to 2000, okay, there's Nikolai, thank you. I prefer to take the urine samples. It depends on what I want to do. Okay, if I want a urine culture, then I will definitely take through cystocentesis. If I have an obstructed animal in the urethra, I have a urethral obstruction, and I want to take a urine sample, I will not be afraid. This is what Jody Lulich say. Please do a decompressive cystocentesis, and we're going to talk about that as well. If I want to collect the uroliths, though, along with the urine sample, then this is a bit different. And I'm going to talk about it later. How do we collect uroliths for sampling? Okay, there are many techniques, like the hydropropulsion technique, but these urine cannot be sent for culture. So it depends on what my urine is designated to do. Is it just for, a simple urinalysis? Is it for culture? Is it to collect uroliths? So we can have different methods of collecting the urine. But for culture, please use cystocentesis. I don't know if the answer is okay. If you need more to elaborate more on that, wait, because we have more in the next slides as well. Okay. So thank you for the question. So you see that from 1985 up until 2000, the formation, the actually contents of the uroliths has changed over the years. We used to have more struvite uroliths, and in 2005, we've seen an increase in the calcium oxalate, maybe because the animals were treated, especially in the canine urolith distribution, maybe because the animals were treated for struvite or over-treated for struvite urolithiasis. For example, people were seeing struvite crystalluria, and they were prescribing diets for struvite urolithiasis dissolution, which was wrong. because we said that you have to have, especially in dogs, you have to have a UTI in order to form the uroliths, and it might be, you know, a false crystalluria as well. So maybe because of these over prevention, we ended up into having the other end of uroliths, which is the calcium oxalate uroliths. Okay, this is one explanation that I can think of. And the same happens in cats as well, with more pronounced, you know, lowering of the struvite uroliths and increasing of the calcium oxalate uroliths as well. Let's see the composition of a urolith. So we have the nidus, which is the nucleus, okay? And then we have the urolith body, and then we have the surface crystals, the shell, okay, of the urolith. And this is very, very important because the nidus from the urolith body and the shell could be totally different, because we might have an initial formation of the nucleus, and then other uroliths, crystals might just go and be layered up on the nidus and form a different stone. So we can have a simple urolith when 70% of the uroliths has one major crystal component. We can have a mixed urolith when less than 70% of the urolith is of one mineral, but without identifiable nidus, okay, shell or surface crystals. Let's say, for example, struvite plus urate. We might have a compound urolith, where a compound urolith is a urolith with identifiable nidus, okay, composed of one mineral with one or more surrounding layers of different mineral composition. So if we know the nidus, what the composition of the nidus, then this is a mixed urolith. If we then this is a mixed urolith. If we don't know the compound of the nidus, if we know the composition of the nidus, then this is a compound urolith. Okay, and we have more layerings of other mineral composition. And we might as well have matrix, which is a non-crystallic organic component of a urolith. And this is very important. Why? Because how we treat depends on the composition of the urolith. And let's say that we have a mixed urolith or a compound urolith. How am I going to select the treatment? Based on what? Based on the nidus? Based on the layering? How am I going, let's say, for example, that we have struvite plus calcium oxalate, which is very, very common, or struvite plus urate. What am I going to do? So what are your thoughts? Please write on the chat box so that, you know, we're together on that. And of course, I'm going to tell you what we're going to do. And now, what about the diagnosis of urolithiasis? So definitely we do all our pre-op work just as prior to endoscopy, just as we do in gastroenterology, in gastroscopy, just as we do in any other endoscopic procedures. The endoscopic procedure is the last in the row after we have done all our pre-op, pre-endoscopy diagnosis. Okay, so in terms of blood count, a CBC might be normal in uncomplicated cases, but in UTIs, in pyelonephritis, we can have leukocytosis with left shift. In serum biochemistry, when we have a urinary tract obstruction, we can have an increased BUN, creatinine, phosphorus, and potassium. Please beware of the high potassium levels. Sometimes, and recently I was in Cyprus and we had a cat that had actually 20, its creatinine was 20, and it was very, very acutely at this stage. This means that I have an acute renal failure, acute renal injury, and this could be due, but there was no stones in the urethra, no stones in the bladder. So this was not, and the potassium levels were up to 11, for example, which is, I don't know how this cat was living, but cats are cats. So what do I have to think? I definitely have to think about a urolith higher in the renal pelvis, maybe in the kidneys, maybe the ureters. Okay, even if it's not shown in my radiographs, I definitely have to do a urography with a CT scan in order to detect if there are any problems in the renal pelvis or the ureters. Okay. Also, we can have bilateral hydronephrosis or pyelonephritis with primary renal azotemia due to renal parenchymal destruction. And we can have hydroureters with, for example, a stone, a urolith in the ureters. Okay. What about now the urinalysis? Let's talk about the urine sediment. The findings often indicate inflammation or infection. We can have pyuria, hematuria, proteinuria, and bacteriuria. Okay. The urine pH is variable. We can have an alkaline pH in dogs with struvite calculi and UTI due to the urease positive organisms. And the urine pH of dogs with metabolic stones like urate, cystine, or oxalate may be alkaline if a urease positive UTI is present as well. Could be variable, most of the time acidic in dogs with oxalate, silicate, and urate stones. And it may be acidic in dogs with cystine stones. And as you saw, I'm saying maybe, because most of the times in real life, you cannot just count on your pH to diagnose the composition of your urolith. You cannot do that. It would be wishful thinking, and we would be grateful if we could take the pH and say, for example, it's alkaline, so it's struvite, it's, acidic, so we might have urate stones or cystine stones, but this is not how it works. Okay. We might as well find crystals, but as we said, we really have to be cautious about how we interpret our crystals. And we definitely have to have a urine culture in dogs with UTI by urease positive organisms that accompany struvite urolithiasis. And in cats with, this is the differentiation here because I'm always talking about dogs. In cats with struvite urolithiasis, the urine culture might be negative, okay? The urine is most of the time sterile in cats. There are other mechanisms forming the struvite crystals in cats. In other urolithiasis, UTI may be a complication and not the predisposing factor. In many urolithiasis cases, we do have a UTI going on, a UTI process going on without this being the predisposing factor for urolithiasis, just a complication that we definitely have to address as well. And if the urine culture is negative, sometimes also as endoscopists, and we're going to talk about cystoscopy, maybe not the next time, but the very next time in 2 webinars from now. We might have, for example, some animals have already taken antibiotics, a long course of antibiotics, or even if they haven't, we culture different microorganisms in the urine and different microorganisms from our biopsies from the bladder wall. So when I do cystoscopy, of course, I'm sending off urine culture with cystocentesis for culturing, but I also send one of my biopsy samples will always be sent for culture in order to see if I have a resistant strain of some kind of, especially in recurrent cases, because these two might give totally different results. Okay, and of course, we trust the culture of our biopsies best. Or when you take out the urolith and you send it off for analysis, for typing, you will always see the composition of the urolith, but you will also culture the urolith. Because if you culture the nidus of the urolith, then you might also find the solution to your problems, what's causing the UTI. Okay. And what about the stone analysis now? How do we send off our uroliths for analysis? As we said, we have the nidus, we have the body, and we have the shell, and then we have the surface. And these all might have the same compositions, but they might as well not. Okay, so never, ever put the stones in 10% formalin because it prevents our quantitative analysis, okay? There are some commercial kits out there for qualitative analysis, but they're not accurate. The optical crystallography is the preferred method. It's not handy in our practices, so we have to send them off to a designated lab that does these kind of analysis, okay? And the mineral type in the nidus layer in our nucleus should be, as I said, our primary focus, because we're going to treat the urolith according to the nidus composition. So let's say that I have a struvite nidus and my body is urate. Which kind of food am I going to give for struvite? Okay, I always treat according to the nidus. And this is the home take message that I want you to take, that when I have a urolith, I always treat according to the nidus, even if this is a mixed urolith or if it's a compound urolith. Okay, let's say that no nidus layer is listed. If we have a mixed urolith, for example, we said that sometimes the nidus cannot be identified, okay? So this should be the focus of, if no nidus layer is listed or the nidus is similar in composition to the body layer, then our next best option is to treat for the body, okay, the body composition. The shell and the surface layers that are being deposited upon the body are significantly different from the composition of the body layer, and they reflect changes in the diet, in the medications, or in the patient's medical condition. So why do I have different layers? Because I might at some point change the diet. So the pH changed. So if the pH changed, then the medical condition and the composition of the urolith changed. This is why we have different layers upon the body of the urolith. Okay, so let's keep that we always treat according to the nidus, and if the nidus is not identifiable, then we can treat according to the body. Hi, Babak. Hi, everyone. And the easiest way to have your qualitative analysis of the urolith and quantitative sometimes, and culture-wise, is to send them off to the Minnesota Urolith Center and to Jody Lulich in order to do the qualitative and quantitative urolith analysis. And this is the form. You can ask it from Hill's prescription diet, and they will give it to you for free. And they can actually, the Minnesota Urolith Center will do this for free for you, for all your patients. Okay, they have more than 1 million, I think, uroliths analyzed at the Minnesota Urolith Center. So don't hesitate to send all the uroliths for quantitative and qualitative analysis. And then, of course, we have the imaging of the urinary tract with radiographs. Please have some good radiographs because they can save you a lot of trouble. They can give you a diagnosis. Let's say, for example, that we have radiographs is our first choice. Okay, So let's talk about radio density, because these uroliths are different in radio density. Okay, we have the calcium phosphate, everything that contains calcium, they're very, very radio dense. Calcium phosphate, calcium oxalate, struvite, and silicate calculi are the most radio dense. Okay, cystine and urate, you might miss them. And this is why in dogs with portosystemic shunts, they might have undergone many ultrasound examinations, okay, yet they might be undiagnosed if there's a very small shunt, intrahepatic shunt that our radiologist cannot actually see. But if you take a urine sample, you might see the biurate crystals and you might diagnose it earlier, even before the urate calculi are there. Okay, so these are the least radiodense, and we might lose them, we might miss them, unless we do a frequent and monitoring urinalysis. If the uroliths cannot be observed in plain radiographs, then we can do a positive or double contrast radiographic studies. Okay, before radiographs, we should always do enemas to remove the fecal materials. This is very, very important because sometimes you cannot see uroliths in the urethra due to the fecal content in the colon. And this is one procedure that we also do in urethral stents. We first do an enema to remove all the fecal material. We put our guide wire in the colon, and then we do our urethrophy, and then we put the stent. Okay, so we definitely have to do an enema, and I know that it's a bit difficult during the course of your clinics, but please do it and have very, very good radiographs because they might help you diagnostically. Calculi that are small, like 3 to 4 millimeters, can be observed radiographically if they are radiodense. If they're not, even bigger, you can miss bigger than those. Okay, do not confuse the blood clots or the bubbles of air for radiolucent calculi on the contrast studies. Okay, so you might shake a bit the animal, especially in the bladder, in order to see if the bubbles are gone or not. The clot will not will differ a bit from the lucent calculi, but there's always, a misinterpretation there, and we should be cautious, okay, in order what we're saying to the owners. And there's always other things that might confuse us in our radiographic interpretation, like radiodense material in the GI tract, calcified mesenteric lymph nodes or adrenal glands, or calcified mammary glands in the female dogs, which is very, very common. So please do not perceive those as uroliths. And sometimes I have some calcified, gallbladders, and they tell me that's a urolith. I mean, please be aware of the anatomy of your radiograph as well. Okay, in the DV, it's even, worse. So let's see here, for example, we have a mid-ureteral calculi here. You see how high up the calculis are. They are not in the bladder, okay? So we really have to know what we're seeing, especially in the DV projection. Okay, and this was verified by the ultrasound as well. Another thing is that the double contrast cystography for urate calculus, for example, you will see how you see that in the plain radiograph, we miss the urine calculi, but in the double contrast, because urate calculi are really radiolucent, you can see them. And as we said, we really have not to misinterpret them to confuse them with blood clots or with bubbles. You can shake the bladder a bit. If it's a bubble, it will go away. And the most important thing that I want you to know is that when you're having a lateral radiograph, I always do right lateral, left lateral, and a DV projection. So please, you have to include in your radiograph the whole pelvis, because you might miss here, for example, you don't see any calculi, but if you take the correct radiograph, you will see that these calculi, you would have missed these calculi, especially in the male dog, in the urethra. Okay, so always include your pelvis in your radiographic examination in order to avoid missing some uroliths, especially in the male dogs. Okay, so lateral radiographs of the male dogs should be centered on the perineum, with the pelvic limbs pulled ventrally and the flexion of the pelvis at the coxfemoral joints. And let's talk about the ultrasound, not in details. The ultrasound is because I know that many of you have ultrasounds in your practices, then it may identify uroliths that are not radiodense. This is a good modality. But of course, it can only evaluate the proximal portion of the urethra. And the ultrasound of the ureters and the kidneys are useful in order to determine if I have, for example, hydroureter, hydronephrosis, or pielectasia, which will lead to the suspicion of an obstruction of the upper urinary tract. Okay, so yes, this is a very good modality. We always do it prior to our endoscopic procedures as well, in order to have an overview. Radiographs and double contrast or contrast medium urethropography and cystography. Palindrome urethropography, we always do them prior to our endoscopic procedures. And if you want to use contrast medium, then you definitely have to wait, or you have to flush the bladder before going in endoscopically, because you will harm your endoscopes. You might wait 1 day. You cannot do them at the same session. Although, having said that, if you have a C-arm, you can do urethropography and stenting at the same session as well, because this is different. This is through fluoroscopy and not endoscopically, okay? And this is how we actually estimate the renal pelvis in order to know if we have an hydronephrosis, because this is very, very important for ureteral calculi, and to know which method are we going to use. Are we going to put a ureteral stand? Are we going to put a SUP? So we definitely have to know all of those things and to estimate the renal pelvis. And there is this classification system from 1, 2A, 2B, 3, and 4. Where the sinus is open, where the in the 2A, the intrarenal pelvis is dilated. In 2B, the extrarenal pelvis is dilated, and the major calyces are dilated. In type 3, we have even the minor calyces dilated, and then we have a parenchyma that's very, very thin. Okay. Full dilation and hydronephrosis. And what about struvite? How do we manage now them? How do we manage them, both medically and on a second layer endoscopically? So in struvite urolithiasis, these are magnesium ammonium phosphate stones. You can see them. They're very radiolucent. They're very smooth. Spherical, ellipsoidal, or a very smooth contour. They may appear wafer-like sometimes, but this is very uncommon. And 95% of dogs that actually have struvite urolithiasis are female, and they have UTIs, concurrent UTIs with urease-positive bacteria. And they form in alkaline urine pH, okay? And what about their treatment? the elimination, if you go into treating the struvite uroliths without treating the UTI, then you haven't done anything. You're up to zero. Okay, so the elimination of UTI infection with the appropriate antibiotic therapy after you have treated with a targeted antibiotic therapy, and after your urine culture and sensitivity test is of absolute necessity. Okay, and of course, calculated diet. The diet is used for 1 month beyond radiographic evidence of urolith dissolution. So if I have a female dog with very big uroliths, like this one, like this dog here, what do I do? If this dog is straining and urinating blood and has hematuria and has, you know, fever and is very unwell and the owners are really, really worried, then I might go into the surgical option, but rarely ever do I do it. Most of the times, what I do is that I go to the medical solution, to the medical dissolution of the uroliths with treating the UTI and the calculated diet. It takes more than 1 month, yes, but it dissolves. You don't need to do a surgery, because an abdomen that's opened, and excuse me from all the surgeons that are in the audience, an abdomen that's opened, it will never be the same again. Okay, how do I do the follow-up examination? And you see here that we have this patient, and after over a month, in a month period, the bladder is empty, no uroliths. Okay, and this dog actually was saved from a very, very, from an operation, which is not a very complex operation. I know that you all know how to do a cystotomy, but the problem is, why do a cystotomy on grounds of a urinary tract infection, of leakage of bacteria into the abdomen, just to take out uroliths that can be dissolved anyway. And our aim is to have a urine-specific gravity of less than 1020 and a pH less than 6.5. Okay, and no signs of UTI. This is very, very important. The full dissolution is expected in 2 to 3 months in most of the patients. Okay, what else can I do? Can I use urine acidifiers? I rarely have used D-L-methionine. Rarely have I used it. Okay, but for those calculi that if we want to make it to speed up the process, or if we want to make it, you know, if it's not responding to the normal calculated diets, then yes, you can add D-L-methionine in 100 milligrams per kg BID from the mouth for dogs that are not administered the calculated diet. You can also give it as an adjunct to the dogs that are receiving calculated diet, but in lower dosages. And of course, we can do the surgical endoscopic removal of the uroliths, or avoiding hydropropulsion if the uroliths are really small in size and can pass the urethra. In female dogs, most of the times we don't have this problem. So it's easy to take them out as long as the diameter of the urethra is enough in order to pass the stones. What measures should be taken in order to avoid the recurrence? And this is the most important thing to know. We have to definitely monitor the recurrence. Urine culture every month for 3 months, and then every 3 to 4 months. So every month, 1 urine culture with cysts and disease, and then every 3 to 4 months, just to be on the safe side. I don't care if I find struvite crystals during the time of the monitoring, but I really do care about finding UTI traces, urinary tract infection that is persistent. I have to do something about it. I have to address this problem, because the urolith will recur. I don't know how much time we have. We're already past the hour. We have many other uroliths to discuss. and we're going to do that in part 2 and the endoscopic solution next time as well. We're going to talk a bit next time. Let me show you what we're going to talk about. We're going to talk about these methods, about voiding hydropropulsion, about the basket retrievals, what kind of sizes you're going to have in your baskets for urology, what other maybe instrumentation and accessories you might use, like laser lithotripsy. And we're going to talk a bit about percutaneous cystolithotomy and the basket retrieval, lap-assisted, laparoscopically assisted, even though I'm not a surgeon and I don't do laparoscopies, but we're going to talk a bit about the method and how we're doing it. We're not going to talk about stents. We're going to have a dedicated webinar on stents. This is very, very difficult to explain without doing the stent procedures because there are different kinds of ureteral or urethral stents that we can put, okay, if the stone is still there in order to bypass the stone or to let the stone void. Okay, so we're going to stop here. Next time, we're going to talk about all the other uroliths as well. And we're going to talk about our endoscopic solutions. Up to here, all the webinars will be provided to you because I know that some of you had some problems with their connection, internet connection. So we're going to send the link of the recorded first part, okay? And all the other topics will be discussed in our second part in July. And then we're going to have a rest in August and see you back in September with our webinar with the FACAVA Congress. You're more than welcome to come in FACAVA. It's organized in Athens, in Greece, 12th to 14th of September. We're going to have an endoscopic, an upper rhinoscopy. We're going to have a rhinoscopy endoscopic workshop in FACAVA Congress and many, many interesting topics as well. Any questions that I can take up to now would be great. Thank you for the attendance today. It was not purely endoscopically, as I said, but we really have to know our boundaries and our the underlying internal medicine basics in order to estimate which are the calculi that we're treating endoscopically and which are not.
Okay. So no questions? Okay, thank you very much for this wonderful webinar. Thank you, Dr. Vasilicki, and thank you all for coming today. If you have any questions, you can contact us from LinkedIn, YouTube, Facebook, or Instagram. We'll share the recording of today on those channels, as well as other information such as more clinic cases, the information of next event, and so on. Don't forget to subscribe. See you next time.